right, good afternoon, everybody. Good afternoon. It's a Sunday fun day with Joe, so just kind of relax, chill out, and enjoy the next 40, 45 minutes with me and just pretty much laid back, big high value subject, atrial fib. For those of you who haven't been with me on my Sunday fun days, yes, you are in my garage, and this is as good as it gets, guys. You've got a 38-year experienced PA in the ER with 32 years of teaching experience hanging out in my garage, guys. And this is about as good as it's going to ever get for you. Trust me. And for those who haven't seen my garage, there's my workout bench. Over there is my kegerator. There's a refrigerator with, of course, non-alcoholic beverages. That's not true, right? And there's my kegerator. I've got Pacifico in there. So you guys are always welcome in my garage. Have a beer with me. And so let's get to this. Okay, let's get to this. All right, so listen, atrial fib, I can guarantee you it's on your EOR. It's going to be on your end of curriculum exam. It's going to be on your PACRAT. It's going to be in your PANCE. It's going to be in your research. So it's always there. This is really considered a high value subject. When the research used to have the levels, they got rid of it, like level 1, level 2, level 3. They're getting rid of it this year. In other words, what subject should you know the most about? It was atrial fib was up there. It was a level 3. It was considered like a very high dense subject. So let's go over this together. I know, like, a lot of times you go over in school and they go over it Mach 3 with their hair on fire and they're like, man, what did they just say? Right. So I totally get it, guys. I totally get it. Right. So I'm going to share my screen with you here, guys. All right. And so let's get to this here, guys. Let's get to this. Okay. All right. So let me move this. Let's get to the slideshow. Let's play from the start. Okay. Oh, I'm sorry. This is not this. Sorry, that's my Kappa conference, guys. If you go to Kappa conference, you can come see my cool cases, guys. If you're in California, you can come see that cases. That's my Kappa conference. Sorry, guys. Open up the wrong slideshow. All right, here we go. All right, so atrial fib, right? So atrial fib. So I'm going to talk to atrial fib, and we're going to get a little bit of atrial flutter because I think a lot of times it's good to put the two together. I do. I think it's important to put them together. So I want you to really just stop for a second right here, because these are the facts that you learn in school, right? Most common cardiac arrhythmia, it occurs as you get older, increases with age, blah, 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 right? You've heard that. Okay, let's try something different. You ready? Try this. I want you to look at your bicep right now. I mean, no, really, look at it. Look at your bicep. Got it? See it? Check out your bicep. All right. See that muscle? See it? Okay. What does it need? No, really, I know this sounds crazy, but what does it need? Well, Joe, it's going to need oxygen and glucose. I totally agree with you. I completely agree with you. Now, if I lack oxygen to your bicep, is it going to work? You're like, no, Joe, it's not going to work so well. Okay, I need this as a foundational fact, just foundation. If you lack blood flow or oxygen to a muscle, it doesn't work. No, exactly. Peripheral vascular disease, that's how it works. Ischemia, that's how it works. Yeah, I see your concept, Joe. It makes a lot of sense. And then imagine if I tell your bicep to work out 24 hours a day, 7 days a week, 365 days. If I tell you to keep just doing curls, you're in the gym, keep doing it. No, keep doing it. Nope, keep doing it. Keep doing it. Keep doing it. What would happen, guys? I mean, no, really, what would happen? In other words, what would happen is that your muscle would run out of steam, wouldn't it? Can we agree to that? Can we just agree that your muscle would run out of steam? So if I demanded it to work all day, every day, even in the middle of your sleep, can we all agree at the end it's going to get fatigued? Can we all agree? So if you overuse a muscle, it gets fatigued. So can we all just agree to those two concepts? Got it? Okay. Watch how this plays out. You're right. As I get older, guess what I'm doing here, folks? That's right. I've got atherosclerosis and I've got decreased blood flow. Don't I? Yeah, you do. And then one of the other things that you'll see with atrial fib is that we're worried that they make clots. So at the end of the day, I want you to start conceptualizing this. So what's really going on in atrial fib before we even turn to the next page? Watch, I'm going to have you come up with the answers already without even showing them to you. So what happened? Well, either I lack blood flow to my atria, or I demanded too much of it, or maybe I vasoconstricted it. Okay, does everybody see that? So lack blood flow to your atria, decrease the blood supply to your atria. Yeah, it's not going to work well. Exactly. High, demand it to work every day, too hard, too fast. Like, yeah, it's going to wear out. Vasoconstricted, it's going to wear out. And then I start to fibrillate, which means I don't work well together. So I'm beating at a different pattern. Next time you get a chance during your rotation at work, take a tube of blood, take it, shake it, just shake it for about, I don't know, 10 seconds, put it on the table, walk away, come back 10 minutes later. And you know what you're going to see? It's going to be clotted off. So you see, that's what we worry about with atrial fib, is that the blood's being beaten around, not rhythmically, very erratically. Boom, 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 boom. That's why I make the clots. That's why we're worried about thromboembolytic events. Does everybody see this? So what we do is we give them anticoagulants. Now, for the 2022 PANCE, for those who are getting ready to take it, yes, at this moment, what is the strongest anticoagulation medicine I got? That is Coumadin. That is true. Now, we're all witnessing the death of Coumadin, aren't we? Because we're seeing Xarelto, Eliquis, rivaroxaban, apixaban, all those things, dabigatran. And what we're finding out is more and more studies are coming out and they're saying, hey, listen, Xarelto and Coumadin, they're the same. The problem is that we don't have the antidote. It's not commercially available. We do have the antidote, it's just god-awful expensive, right? How expensive is vitamin K, the antidote to Coumadin? Come on, guys, you can buy it at CVS right now if you wanted to. Got it? Or does everybody see what's going on here? All right. So on the boards, I have a really high-risk person. Yep, it's still Coumadin. Now, this will change 10 years from now. So now does everybody see, from a concept point of view, just concept, my atria is either irritated because it's lacking blood flow, is either irritated because it's being demanded too much, or it's either irritated because it's vasoconstricted. All right. And now does everybody see, I get atrial fib. What are you worried about? I'm worried about making a clot. Okay, that's what I'm worried about. I'm worried about making a clot. And so that's the key point. All right. So you see, on a normal day, just a normal day, we got that SA node goes to AV node, atria contracts rhythmically, goes down. Everything looks great. It really does. And so those atrias are up in my left and my right atrias, right? And then we got that little area over there, right? We call the left atrial appendage. So I want you to view that as a cul-de-sac. So imagine you got a cul-de-sac and your left atria, and that's literally what it looks like, guys. It's like a little cul-de-sac. So now imagine I got all this turbulent blood and I'm making clots. Hey, can you make a clot and store it in your cul-de-sac? Can you do it? You're like, yeah, of course I could, Joe. That's what we worry about in atrial fib, that they've got this clot sitting in the left atrial appendage. This is what we're worried about. This is what we're worried that this thing might dislodge and throw clots and emboli all over the place and cause all types of problems. So that's what we're really after, guys, is that. Okay, does that make sense to everybody? I mean, I hope that makes sense, right? Okay, so we got the SA, AV node, atrias come down, stimulate the AV node, and down the bundle of His I go. Got it? So there I go, right? So I go down the Purkinje fibers, right? And there I go, right? Does everybody see this? Nice and normal. Okay, does everybody see the P, QRS, and the T, the P, the QRS, and the T? Okay, Joe's rule. And don't worry, we practice. I got a bunch of rhythm strips coming up. Joe's rule. Joe's rule goes like this. You look up before you look down. One more time. Look up before you look down. And if you didn't get that for the first 2 times, here it is for the 3rd time. Look up before you look down. In other words, look up at the R wave pattern. Look up. Got it? Okay. When I got normal sinus rhythm, how's the R wave pattern? It's regular. Look here at atrial fib. Look at the R wave pattern. It's irregular. Look down at the dirt. You're like, well, Joe, I think no, it's not flutter because it's too messy. Yeah, this is all over the place, Joe. So I've just got trash on the floor. So what's the irregular rate, irregular R wave pattern with trash on the floor? Atrial fib. Just a teaser. Don't worry. We'll get deeper into this in a second. I promise I'm not leaving you alone here. So the natural tendency of atrial fib is to become chronic. This is what we worry about. Okay, now does this make sense to you guys? The atrial ischemia? Now does this make sense to you? You're right. I'm lacking blood flow to my muscle. How's it working? Not too good, Joe. And now do you understand? If I got coronary disease, the blood vessels that are feeding your heart are compromised. So how's your blood flow? Compromised. How's your oxygen level? Compromised. Does everybody see this now? Does that make sense to everybody? How, in other words, any type of cardiac ischemia is going to cause atrial fib. Now, does everybody see the concept? So you lack blood flow to my atria, I'm going to give you atrial fib. This is what I'm going to do. And now does everybody see how the blood vessels that are feeding my heart, my coronary arteries, are actually decreasing the blood flow? And this is what's causing the atrial fib. This is one of the most common causes. And then you'll get like these really, I call the zebra cases. The zebra cases. The zebra cases are like, right, you probably read up like on the collagen vascular disorder and viruses and just irritating the heart itself. This is true. They're there, but they're rare. And just to give you a little peek down the rabbit hole, just a little peek, just a little peek, just a little peek. You see, guys, when I'm dealing with the myocarditis and the pericarditis, right, that's usually our Coxsackie virus. Remember that? Okay, that you memorized at school. See, what you got to understand is that if I'm the Coxsackie virus and I'm causing myocarditis or pericarditis, does everybody see? You're like, yeah, I'm just not going to stop eating at the myocardium. What's this thing over here called? Oh, it's called the coronary artery. Oh, can I eat this? Of course you can. It's on the menu. Which means, oh, wait a second, Joe. Then you're telling me in a myocarditis or pericarditis that it could actually start eating at my coronary arteries? Exactly. And wait a second, Joe. If I eat at my coronary arteries, then I'm going to lack blood flow to my atrias. Exactly. Which means, wait a second, then I'm going to decrease blood flow to my atrias. Exactly. Which means, oh, hold on. Then I get atrial fib. Now, does everybody see the connection? Does everybody see this? It's rare, but there. And then the last one, the collagen vascular disorders. All right. This is where we need to stop. Need to go drop down a rabbit hole with Joe. Just come on, let's go down the rabbit hole with me. Just here we go. Quick trip. You see, guys, when I'm an autoimmune disease, pick one. I'll let you pick one. Rheumatoid arthritis, lupus, Goodpasture syndrome, scleroderma. Just pick one of your choice. I'll let you pick one. You see, guys, when I say vasculitis, what I'm really telling you is you're autoimmune. That's exactly what you're saying. See, I always teach my students, when I do my review classes, right? I just got back from UC Davis, right? So what I always tell my students is this. It's like, listen, when you're dealing with an autoimmune disease, let's just say you're dealing with lupus. What you have to understand is that lupus is the driver, but he's got these passengers in the back seat. He's got these passengers. He's got these guys that come along with these other symptoms. Remember uveitis and iritis? Yeah, go ahead, inflame your uvea. I'll wait. And you're like, no, I can't inflame my uvea. Then can I ask you another question? Who else is around to inflame it? It's just you. You see, you ate your uvea. Iritis, who's around to eat it or inflame it? That would be you. Vasculitis, who ate your vasculature? That'd be you. Remember alopecia? Yeah. Who ate your hair follicles? Well, who else is around? You. Remember vitiligo? Yeah. Who ate your melanocytes? That would be you. And remember Sjögren's disease? Another passenger. So you see, guys, uveitis, iritis, vasculitis, alopecia, vitiligo, Sjögren's disease. Guys, welcome to the autoimmune disease passenger bus. They're passengers. Yeah. They sit in the back of the bus. So Crohn's disease. Go ahead, look it up if you want to. Go ahead, knock yourself out. Look up PANCE pearl tips. Look it up, guys. But I think the concept's better. Crohn's disease, can they get uveitis? Yes, they can. Hey, remember Hashimoto's disease? Oh, wait a second. That's right. That got vitiligo and Hashimoto's is autoimmune. Now, out of the rabbit hole, back out. Hi, you got an autoimmune disease. Can you cause a vasculitis? Sure can. Hey, wait a second, then can you eat the vasculature of your heart? You sure can, which means I can lack blood flow to my atrias, and you sure can. Get it now, folks? See how the autoimmune diseases can cause AFib? Does everybody see this? These are the rare ones. These are the zebras. I'm agreeing with you. These are zebras. All right, these are zebras. Okay, so I just want to keep that in the back of your head. That's all. Holiday heart. Okay, so alcohol is a big irritant, isn't it? Right? So what happens in holiday heart, guys? What do we do with the holiday heart? Just tell them to stop drinking. right? So how do we treat AFib with holiday heart? And remember, alcohol is an irritant. Did it irritate the atrias? Yes. Do your atrias going to work when they're irritated? No. So what do we do with holiday heart? Stop drinking. So that's that test question that rears his head about the guy that went to the, went out with his friends for the weekend, maybe went to a bachelor party, or maybe it was a Christmas party, something like that, some type of, celebratory event. And then he comes back. Okay, watch how much is going to make sense. You ready? Watch. Guys, what's cocaine? Now, I mean, it's a stimulant. I'll give you that. But what does cocaine actually really do? Guys, it's a vasoconstrictor. Where? Everywhere. Hey, you just did a line of coke. What'd you just do? I vasoconstricted where? Everywhere. Which means, can I vasoconstrict the blood flow to my atria? Of course you can. Remember you read about the cocaine and the MIs they can have, and the cocaine and the strokes they can have? Back to the vasoconstricting. And then, come on, guys, we don't see that much coke anymore because it's too damn expensive. What do you and I see? I mean, come on, guys, I'm going to go to work in a couple hours. Come with me. Give me a break. I'm working at Hogue, Newport. We'll see tons of this. What is it? I mean, it's your meth heads, your tweakers. Come on, your meth heads. Nothing against most people, but that's just a nasty drug. Oh, that's a nasty drug, isn't it? And what does methamphetamine do? It's a vasoconstrictor. What are you doing to the heart, guys? Vasoconstricting. What can you run into? AFib. Everybody see the concept here? Okay, remember I was telling you the other one that you could run into AFib? So does everybody see how the lack of blood flow would do this? Everybody see this? Lack of the blood flow would go right here, right? Does everybody see this in the cocaine and the meth? Okay, tell your heart to go. Go, 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 go. Just like remember I was telling you to do the bicep curl all day? You're like, damn, Joe, I get fatigued. Exactly. What is one of the most potent hormones that floats in your body? Guys, it's thyroxine. What is thyroxine? It increases the basic metabolic rate of every cell in your body. So when I've got hyperthyroidism and I'm telling my body to go, it's going 24/7, 365, even on leap year. And now your heart's like, man, I'm done. Dude, you got me working out every day and I haven't had a day off to recover. Now does everybody see this? And now does everybody see the pheochromocytoma? That's right. The pheochromocytoma releases what, folks? It releases epinephrine. And epinephrine is what? A stimulant, makes your heart rate go up, and it vasoconstricts. Oh, then I'm vasoconstricting the muscles to my heart, which means, oh, wait a second, I'm back to AFib. Now does everybody see it? So now does everybody see how the coronary artery disease causes it? It's lack of blood flow. Now does everybody see how alcohol does it? It's just an irritant. Now does everybody see how cocaine and meth vasoconstricts and does it? Now does everybody see how hyperthyroidism and pheochromocytoma is just demanding the heart to work all day? And we had the zebras, right? We had the zebras in the previous one. We had the zebras, the myocarditis, the pericarditis, and we had the colon vascular. Then we had the zebras. They're rare. They're there. But this is Monday through Friday over here. So now you get it, folks? That test question they were asking you on the end of rotation on the PANRE. What was the most important laboratory test to order on your individual with AFib? Guys, the answer was TSH. Because you see, guys, what's the most common presenting symptom of Graves' disease? In other words, going too fast. Guess what the answer is, guys? AFib. And then sometimes we'll see it after strokes. Okay, so does everybody see kind of the etiology of AFib and how this comes around? So it's an irregular heart rate. Don't worry, we'll go over it. Remember, the R waves are regular, irregular. They are irregular. They get the palpitations. They get the shortness of breath. They get the rales with it, right? Okay, Joe's rule. One more time, Joe's rule. Look up. Look at the R wave pattern. Regular, irregular. It's like, it's completely irregular, Joe. Exactly. Look down at the dirt and you're like, this is just trash. Because remember, atrial flutter is very smooth. Does this look smooth at all to you? And you're like, no, it's just junk, Joe. Exactly. What's the irregular R wave pattern with junk on the floor? AFib. See, look at the R wave pattern. See how regular it is? See it? Now look down at the dirt. Oh, I got a P and a QRS and a T and a P and a QRS and a T and a P. Oh, that's normal sinus rhythm. And Heck, I could find one under dark line. So 300, 150, 100, 75, it's normal sinus rhythm. Exactly. So does everybody see how the P waves are very morphologically the same? See them? So that's what the textbooks will talk about is the irregular morphology. Your translation, irregular morphology, trash. Got it? What's irregular morphology to you? Trash. It's trash on the floor. What's regular morphology? Regular P waves. Now, does everybody see what those academic books are trying to say to you? Does everybody see this, right? Okay. Look up regular, irregular, folks. It's irregular. Look down at the dirt. You're like, I can't make a damn thing out of this. I guess it was a T waves, but man, I just can't see jack. So guess what that is? A fib. Okay. 12 lead EKG handed to me. I remember this guy. Okay. Regular, irregular, folks. Just look at the R wave pattern. It's irregular. Look down at the dirt. You're like, oh, look, Joe, I found one P wave. No, it's got to be every single one. And you don't have anything close to that, do you? Everybody see this? See how irregular that is? You're like, yeah, that's kind of wide. That's not regular, Joe. Nope, not regular. And it's trash on the floor. So what do you have? A fib. So when you get these 12 leads, guys, what I always tell everybody to do in a 12 lead, always look at the rhythm strip first, which is always at the bottom. Guys, it's usually on the bottom, the 12 lead. So you'll have your, like this is, where you got V3, V4, V5, this kind of thing. So I want you to get in the habit of looking at the rhythm strip first. Got it? Because this will glean the most information right here. Then we look up and we can all agree he's got ST segment depression in V3, V4, V5. I mean, he's got some ischemic changes, doesn't he? But now, does that make sense to you? He's got ischemic changes, which means his heart's ischemic, which means his muscles are ischemic, which means the atria is ischemic, which means, oh, it doesn't work. Oh, there's the fib. Exactly. Tough one. Just look at it. Just look at the R wave pattern. Just follow it. Just get one that you're comfortable with. Let's take V6. Regular, irregular. It's like, these are nothing like each other. Okay, look down at the dirt. You're like, crap, I can't find any P waves. This is all trash. Exactly. What do you have? A fib. So what do? So we'll do the EKG, we'll do the chest x-ray, we'll do the blood work. Of course, we'll do the troponin one more time. What's the most important lab test to order, guys? What's it going to be? TSH. Does everybody see this? It's going to be my TSH. Remember, it's very common. Then comes that question, and you've seen this question about the transthoracic versus transesophageal. Okay, guys, there's no comparison. I hope during your PA career, if you get a chance, guys, to see a transesophageal echocardiogram, oh my God, so I can tell you, the difference is crazy. Like when we're in the ER, we can get the transthoracics, so sometimes I'll do my own there in the ER, right? And so I'll do it, right? Like I had a guy the other night ago, IV drug abuser, fever, murmur. And so I did the, transthoracic. And so I'm there. Of course, I could look at his tricuspid valve going, yeah, some vegetation's on this. So he's probably got endocarditis. And, we started the antibiotics and all that kind of good stuff, right? And so I remember telling the cardiologist going, hey, yeah, it looks like it's, he's got some vegetations. He's like, okay, great. We'll order the transesophageal. The next morning, guys, they were measuring the 3-dimensional sizes of the vegetations. All I could tell you was like, tricuspid valve looks jacked up. Yeah, it doesn't look good. There's something on it. That's all I could tell you. But the transesophageal was measuring it. Guys, there's no comparison here. This is the Wright brothers plane versus the YF-22 Raptor. Got it? For those who don't know, it's just very fast fighter jet. Got it? So they're right. So they're both, they're both echocardiograms, but this is so much better. So anywhere on the boards, they offer you transesophageal. What's your answer? Transesophageal. What's the best initial test? We can argue this. What can I do in the ER? Oh yeah, we'll do a transthoracic. We can get it down, but it's just down and dirty. It's not that good. But what's the better test? Transesophageal. So on the boards, on your research, guys, what are we taking? We're taking transesophageal always. So they need to prove to you why you take transthoracic. Does everybody see this? Okay. So then comes the treatment. So what do I do with AFib? So I see the ischemia, I see the irritation, I see the vasoconstriction, I see the collagen vascular disorders. I see that. You know, I get all this, Joe. I see what you're saying. And I see, you know, the cocaine, I see the methamphetamines, and of course I see the demand, which was hypothyroidism. Okay, so I see your point, Joe, about lacking blood flow to the atrials. Okay, so you made your point here. So now what do we do? Well, if they're hemodynamically unstable, you're in a bad place. We just got a cardiovert. So you're in a bad place. Got it? You're just in a bad place. But if they're hemodynamically stable, now we've got some ideas. See, if it's less than 48 hours, I can cardiovert them. You get it? I can cardiovert them. But if it's greater than 48 hours, then I've got to anticoagulate them before I can cardiovert them, because we're worried about that left atrial appendage. Remember the cul-de-sac? We're worried that you made a clot there. Okay. On the boards, on your endorotation exam, on the PACRAT, they must give you a timeline to cardiovert. And they're not going to say 6 hours, 7 hours, or 12 hours. They're going to try to jack you up. They're going to do stuff like, well, you know, this guy started having palpitations at dinner, and he's here in your ER at 1. Can you do it? You're like, oh, yeah, that's less than 40. So they're going to give you some type of moment in the day. Got it? Oh, he started having palpitations at breakfast. Oh, he had palpitations when he got to work today. Does everybody see this? So they're not going to give you, oh, he's had this for 7 hours. They're going to give you some type of timeline, like according to his day, what he's doing, right? So the first thing I want to do is rate control. Got it? So I need to slow down the rate, because we know when you get to the AFibs, and you know, if you look at the studies, guys, we can get into this academic debate. We sure can. But one of the studies that just recently came out was saying that when AFibs maintain pulses usually higher than 120 to 130, this is when, you know, you let them sit there too long, they'll make a clot. Does that make sense? Yes. So this is why we try to keep it below 100. That's when we call it a controlled rate, because it's below 100. So what's the medications we do? Well, the first ones we do that we like to use is calcium channel blockers. Okay, so let's stop here. Let's go down a rabbit hole real quick. Let's go get a nugget real quick. Okay, just go get a nugget. Okay, I want you to picture in your head the SA node and the AV node. You see them? See how they're separated? Okay, I want you to imagine 5 lanes of traffic, which we'll just arbitrarily pick the number 5. So you ever see the 5 lanes of freeway traffic going from between the SA AV node? Does everybody see this? All right, guys, you've been on the freeway. What happens to the freeway when they close up some lanes? Does the speed of the traffic increase or decrease? It decreases, doesn't it? Right? I mean, you roll down your window, you start talking to your neighbor. Hey, how you doing? Good. How fast are you going? 10 miles an hour, right? Especially here in Southern California, when they close off lanes, it's already busy enough as it is, right? So when I close up lanes, I slow up traffic. Guys, guess what calcium channel blockers do? They close up lanes. So you see, they serve as a roadblock between the SAAV node. And what they did to you in school, remember that DHP, non-DHP? Remember that? You're probably shaking your head going, oh God, Joe, yes, I remember that, blah, 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 blah. Oh, please stop bringing up bad memories to me. All right. I want you to view it this way. You ready? Okay, guys, I know this is going to sound crazy to you, but just go with me, all right? I always say if you make fun of it, you remember it better. Guys, where do you find pine trees? No, really, pine trees. Where do you find them? And you're going to go, that's a stupid question, Joe. You find them outdoors in the mountains. Okay, can we agree that they're outside? Can we agree to that? Can we just all agree that pine trees are found outside? Very good. Which means if it ends in the word pine, P-I-N-E, like amlodipine, it's a pine tree. What's that? Oh, that's something that goes home. That's an outpatient drug, which means, oh, wait a second, Joe. Then you're telling me the ones that don't end in the word pine are inpatient drugs. They're the stronger dogs. Exactly. Welcome to diltiazem. Welcome to cardizem. And we could put verapamil here too. You're right. You'll see people go home every now and then with cardizem, diltiazem. That is true, but that's rare. So you see, you come to the ER with me and someone's got AFib, rapid ventricular response. So what are we doing, guys? We're putting them on a cardizem or diltiazem drip. That's what we're doing. We're doing that. Makes sense? And then we use verapamil. We don't use verapamil as much anymore, guys. The reason being, it's too strong. It's like, damn, this is a calcium channel blocker, you know, as a, it's like a calcium channel blocker with a pit bull. You're like, this is quick and dangerous. Got it? All right, does that make sense to everybody? Okay, so now, does everybody understand? So when they're asking the question, who's the stronger calcium channel blocker? You're looking for the one that doesn't end in the word pine, because you're not outdoors looking for a pine tree. You're indoors trying to take care of atrial fib. Does everybody see that? And then we could also use esmol. Sometimes we'll use it as a beta blocker. And DIG we can do, but DIG doesn't really do much about the rate. It just increases contractility. So does everybody see this? Okay, and then, so first line therapy is my cardizem, diltiazem. Those are my calcium channel blockers, right? That's my non-DHPs. Those are my strong ones. And then my second line therapy, that's my beta blockers. You get it? There's the esmolol. There's metoprolol. Got it? That's metoprolol. Okay, so let me just help you. Just a quick little trick. So the way that you always remember how metoprolol is the most beta 1 selective drug, right? So I always tell everybody metoprolol starts with the letter M. Metoprolol is manic for beta 1. He is absolutely manic for beta 1. So he loves beta 1. That's all he loves. He's manic. So which is the most beta 1 selective drug? Oh, the manic guy. Who's that? Metoprolol. Does everybody see this? Okay. So now does that make sense to everybody? Okay. So on the boards, PACRAT, end rotation, end of curriculum exam. What's your first line therapy in treating AFib, rapid ventricular response? My answer is cardizem, diltiazem. What's my second line therapy? I could use the beta blockers. Which beta blocker? Well, I just want to lower his heart rate. Well, who's the one that just lowers heart rate? In other words, he's manic about beta 1. Oh, that's metoprolol. Exactly. And then comes this question about WPW. Oh, good morning. Who's seen this question? I know you have. You're all probably just over there laughing right now going, damn, Joe takes our exams, doesn't he? Yeah, I've seen this. You have no idea how well I know students. You have no idea, right? You have no idea how well I know you guys. You know what cracks me up? This being me and you, as educators, we laugh at students because you guys realize you guys are worthless after lunch. You know that, right? After lunch, you're worthless. You're like, why even have PE school after lunch? You guys come back, you're like, I always crack up, especially PowerPoint, after lunch, dark room. Oh, good night, right? You guys are asleep. You're like, Joe was in our class. Oh, God. Anyhow, this question's always there, isn't it, guys? This Will Parkinson way. So let's do this together. Gotcha? All right. So procainamide, but let me tell you why. Okay. In WPW, what I've got is this back street. Everybody see this? I've got this back street. I got this shortcut. So instead of going the nice normal way, which is right here. Got it? That's the nice normal way. SA, AV node, go around the atrius and come down. Go around the atrius, come down. Does everybody see this? That's the nice normal way. So I got to go around and then I'm there. I go around and then I'm there. Except this time I'm like, good night. I'm here. I'm here. I'm here. Which means it gets in there quicker. So that's that so-called delta wave. You get it? See, here you hit it. I go around. That's the pause. That's that less than 0.2 milliseconds getting here. Does everybody see this? See how long that takes? See how short that is? Everybody see the difference? That's the delta wave. Okay. So think about this for a second, guys. Just give this some thought for a second. Let's just be honest with each other. If I put a calcium channel blocker, and he's going to be right here. If I put a calcium channel block right here, and I'm blocking that SAV node, like is what we talked about, right? With AFib, rapid ventricular response. This is still open, which means, oh my God, all the traffic's not going to go on the freeway. It's going to go on the back street, which means I'm going to make this worse. Much worse. So what drugs completely contraindicated in people with WPW is a calcium channel. It won't work because all I'm going to do is block the freeway. And the only thing, remember, they still have freeway, but they got this back street. So if you close the freeway, where are they going? The back street. So that's going to make it worse. Does everybody see this? So now think about it. Beta blockers, are you still closing off the back street? No, I'm just here, Joe. I mean, I could see it outpatient, but if he's got AFib, I'm not doing much. Exactly, which means welcome to procainamide. See, procainamide is the guy that's sitting up here at the AV node in the ventricles. He decides who comes in. He decides who's coming down to play in the ventricles. Does everybody see this? So here comes that short circuit, taking the shortcut, not the long way, the shortcut. Hi, I'm procainamide. No, I'm the crossing guard. I decide who comes in, who doesn't come in. Does everybody see this? I decide who comes down the ventriculars area. Does everybody see this? That's procainamide. So what is the treatment of choice for atrial fib, rapid ventricular response? in AFib? The answer is procainamide. I know there's a Roche review question. I was shown to me by the UC Davis students just recently where procainamide was there, and they said that was not the right answer. Listen, nothing against Roche. I think it's a good testing bank, but I can tell you occasionally they got questions in there that are just dead wrong. And that question is just dead wrong. It's just dead in the water wrong. So it's all I can tell you that, the answer, and in the real world, what do we use? We use procainamide. We do not touch calcium channel blockers. And that was actually the answer to that thing was the calcium channel, which is not true. So does everybody see how procainamide's the answer? Everybody see that now? Okay, good. So remember, the calcium channel blockers are a roadblock. Get it? I got AFib, rapid ventricular response. What do you do? Roadblock it. Got it? Does everybody see this? And there I go. So I roadblock it. That's how it works. Makes sense? Which calcium channel blockers? The ones that don't end in the word pine. Exactly. Then I got to control the rhythm. So does everybody see how we control the rate? And now I got to control the rhythm. All right. Does that make sense to everybody? I got to control the rhythm. That's flecainide. Okay. I always say view flecainide as kind of the massage therapist for your atrias. When your atrias are tight, and they're really stiff, and you need someone to come relax them. That's who flecainide is. And then we can use amiodarone at times. This works well as well. And then anybody see the radiofrequency ablation? Anybody seen this? We have electrophysiology cardiologists, right? That's all they do, guys, is they're the electricians to the heart. They don't care about the valves. They don't care about any of that, guys. They're the electricians to the heart. So this is what they do, guys. So if you ever see this, I'm telling you, if I had AFib, don't give me the calcium channel blocker and Xarelto. Let's go ablate it, right? So you'll see that in the real world. Okay, the CHAD score. Okay, I know everybody sees this and they get upset, right? Okay, all we're saying with CHAD, and I want this in your head now, when they say CHAD score, they're just saying, how likely am I to make a clot? That's all. And now I want you to look at this. Does everybody see, as I get older, you get it? I'm older. I'm lacking blood flow to my heart. Does everybody see the age? Everybody see this? So when I'm over than 75, it's like, oh, he's high risk. I had a previous stroke. He's high risk. So now that CHAD score, you need to start viewing it like, what's the likelihood of this guy making a clot? Don't memorize the numbers because that's just going to drive you to drinking. That's all that's going to do. Right? If you want to go drinking, come over to my garage. We'll have a Pacifico. Not a big deal. But does everybody see this? Does everybody see the age? Get it? Previous strokes. Oh, I get it, Joe. I see your points. You're telling me the 65-year-old guy with vascular disease, and if it was a female, she's high risk. Exactly. Now does everybody see this? So don't sit there and memorize it. Just go, as I get older, 65, 75, that number becomes bigger. And now does everybody understand, if I got a previous stroke, I'm up there. I am totally up there. And that's what I'm trying to get inside your head with CHAD. Got it? That's all. So how do we anticoagulate? So we need to stop making the clot. So we control the rhythm. We use the calcium channel blockers. We use the beta blockers. We did procainamide if it was WPW. They went home. We gave them the massage therapist. That was flecainide. Good job. So now let's anticoagulate. So on the boards today, 85-year-old guy, aortic stenosis, AFib. The guy's just so high risk. That's his middle name is risk. You're right. We can use Coumadin. But then we'll get these individuals that come floating by and their CHAD score is like 0. Got it? They're not older than 65. They don't have any vascular disease. They're nothing. They're like this young adult. We call him the lone wolf. No coronary disease. Nope. He's young. No thyroid. Nope. No coronary. Nope. So you got this healthy 43-year-old triathlete who's got AFib. Everybody see him? And you're like, okay, so I just want to lower his heart rate so he doesn't get too high of a heart rate. So what's the beta blocker that's manic for beta 1, guys? Oh, metoprolol. So I'll use that to lower his heart rate. Yeah, no, exactly. Good call. Now they want you to anticoagulate him. Maybe they're saying, well, we're just worried that we might want to anticoagulate. Like, okay, so what do I do? So does he need the Xarelto? Does he need the Eliquis? Does he need the Coumadin? They're like, man, that's kind of hitting him pretty hard, Joe. Let's just antiplatelet him. Let's just give him something easy. And then they come up with this thing, and you've seen this question a bazillion times, have you not? Aspirin versus Plavix. Okay, So let me just help you guys out. Aspirin's a cheetah. He's quick. No, aspirin's quick. Cheetah, 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 cheetah. What's aspirin? He's the cheetah. So when you use aspirin in an acute event, remember MONA, morphine, oxygen, nitroglycerin, aspirin. What did we use as a code neuro, code stroke? What's the first medication we use in ischemic stroke? Hey, I need a cheetah. Aspirin. Does everybody see that? And then there's clopidogrel, which is stronger than aspirin. And clopidogrel, does everybody see the word clogged pipes in it? Can never kind of imagine the word clogged pipes? Hey guys, guess what we use after stents? Yeah, clogged pipes. Plavix is for plumbing. Yeah. And so Plavix is a stronger antiplatelet medication. So guess what we give the lone wolf for AFib, folks? The clopidogrel. Does everybody see that? Does that make sense to everybody? And then, of course, we use Coumadin. This is for the high risk. This is the Chad off the score. He's older, hypertension, diabetic. Does everybody? He's just a hot mess. He's a hot mess. Got it? That's that aortic stenosis. Now, does everybody see when we pull out the Coumadin? It's for the super high risk. You get it? Like, man, you're stuck. You got to go. Now, this is where you're at today, isn't it? What did you see? Oh, Joe, I saw a dabigatran, rivaroxaban, a apixaban. Exactly. So you see, that's what we would do with the regular atrial fib person. Got it? They'd go home with the apixaban or the rivaroxaban. And come on, guys, you ever seen the Xarelto commercial? You swear like you're watching a commercial for Whole Foods, right? Jerry Wesh is eating a salad. Chris Bosch is eating a salad. Arnold Palmer's eating a salad. Everybody's eating a salad. You're like, what salad dressing are they selling? Right? And you're like, no, what they're really saying to you is that, hey, I can eat green leafy vegetables. Got it? I don't need to measure it. You can just take it. Here's a little footnote you probably don't know. You ready for this one, guys? How quick does Xarelto work? So let's just say you get rivaroxaban. Got them? So you put them on the Xarelto starter pack. Got it? Okay. How quick does it work? So let's just say you popped your 2 Xarelto. That's how the starter pack starts, with 2 pills at once, right? So let's just start with that. How quick does it work? Answer, 3 hours. Yeah, think about that, guys. 3 hours. You ready for this one? Let this one sit in your head. Hey, guys, how long does it take Coumadin to work? You're like, oh, damn, Joe. It takes like 5 to 7 days, and then I got to get an INR between 2 and 3, and they can't eat green leafy vegetables. And now does everybody see why we're leaning more towards the, towards the newer stuff? God, does everybody see this now? Now, does this make sense to everybody? Okay, I hope it does, right? Okay. And then there's atrial flutter. Okay, and atrial flutter, here's the catch. It can be regular or irregular, the R wave patterns. Does everybody look at this R wave pattern? They're down, but look at them. It's irregular. Look at the dirt. You're like, oh, that's very rhythmic and sawtoothy. Everybody see this? And now, does everybody see this is very, right? Does everybody see this? Okay, so now this is irregular. See the rhythmic flow to it? See it? Nice and rhythmic. Yep, and they're the same. They have the same morphology, right? And then regular, irregular, and you're like, yeah, wow, Joe, this is kind of looking a little regular. So 1, 2, fire, 1, 2, fire, 1, 2, fire, 1, 2, fire. This is when it's rhythmic, guys. That's when we call it either a 2-to-1 block or a 3-to-1 block. Does everybody see this? Okay, so remember, the key thing in atrial flutter, it's sawtooth. The beauty of atrial flutter is we treat it the same. Yeah, that's the best part. We treat it the same. So guess what we give them? Calcium channel blockers. What are they going to go home with? My massage therapist. What's the massage therapist's name? Fleckenize. Going to relax the atrias. Got it? And here's the key point. Do I have to anticoagulate prior to cardioversion atrial flutter? No, I can just cardiovert. Does everybody see this? Make sense? So we could treat it chemically, or we could cardiovert. We do one of the two. It's not a problem. So there, okay, so now as a recap, okay, just as a recap, right? As a recap, what I want you guys to understand is that as a recap, so let's just go over this together as a group, as a recap. Got it? As a recap. Okay, so what did I got? I had atrial fib. What did I do? I lacked blood flow. I vasoconstricted or irritated my heart. How'd you lack blood flow, Joe? I did coronary artery disease. I got older. I lacked blood flow. What did you get? AFib. How'd you vasoconstrict? Well, I did cocaine. I did meth. And one more. What's the other what's the common, come on guys, I can guarantee you, you walk outside somewhere today, you'll see someone vasoconstricting. What are they doing, guys? Smoking. What's nicotine, guys? Vasoconstrictor. Where? Everywhere. Hey, what are you doing to my heart? Vasoconstricting. And now do you see how smokers and COPDers can get AFib? Everybody see that? And then the demand. Okay, so you're telling your heart, go, 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 go. Workout, 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 workout. What's your heart going to do? It's like, dude, I can't work out every day. You got to give me a break. There's the thyroxine. There's the pheochromocytoma. Who irritated your heart? Alcohol, right? High doses, right? Those, so, and what are you doing at holiday heart? Stop drinking. Get it? Stop drinking. It's not good for you. I mean, low doses are good, but these people like go overboard. Can we agree to that? And then remember, our wave pattern, regular, irregular. It was irregular. What do you see on the floor? Trash. I couldn't make anything. The morphology was all irregular. I couldn't figure out anything. I found one P wave over here, Joe, but nothing over here. And then how did I treat it? AFib, rapid ventricular response. What did I do? Okay, if they were hemodynamically unstable, what did we do? Cardioverter. If they're hemodynamically stable in less than 48 hours, I've been having palpitations since breakfast. I went to a meeting this afternoon. He's had palpitations. What can we do? We can cardiovert. Then they asked me the question about how to chemically treat them. What do I do? Calcium channel blockers. Which calcium planner? The ones that don't end the word pine, because the pine trees are going outside. So that's my cardizem, diltiazem, verapamil. Then comes that WPW question. Remember, that has that back street, doesn't it? Can you fight WPW up between the SAAV node? You're like, can't do it, Joe. So where do you fight WPW? Down at the ventricles, at that AV, right at the AV node, and down by the ventricles. I can fight down here. What medication fights down here? That's procainamide. So how do I treat WPW, rapid ventricular response? Procainamide. And that's exactly what we do, guys. And for those of you who are thinking outside the box, guess how we treat SVT with people with WPW? Because the adenosine works up, doesn't work down. Guess what we use, guys? Procainamide. Everybody see this? Okay, so this is starting to make a little bit more sense. And then comes the question about transthoracic versus transesophageal. Guys, come on, guys. There's no comparison. Who's better? Transesophageal. Got it? We're taking that. So see, the test question's got to push you to transthoracic. Got it? You're like, ER, initial, right now, you're like, okay, fine, I'll do the transthoracic, but I'm telling you guys, from someone who works in the ER for 38 years, trust me, the cardiologist is ordering transesophageal in the morning. Make no mistake what he's doing. God, they don't like the transthoracic. It's like, it's okay, not great. Then the next question that comes to play, okay, so what do I do with the lone wolf? The young, healthy AFibber. There he is, just has AFib for whatever reasons, just young, healthy guy, just sitting there. Here's your lone wolf. He's got nothing. His Chad score doesn't even exist. He doesn't even know who Chad is. I think Chad's his cousin. He's like, who's Chad? I've never heard of a Chad score. That's how healthy he is. Got it? So what do we do with that guy? If they have to anticoagulate him, I'd probably give him an antiplatelet. You want to give him aspirin, the cheetah? Oh, clopidogrel, the stronger guy. Which one do you give him, guys? The clopidogrel. Remember, what's aspirin? Cheetah. He's cheetah. You get it? He's quick. So what are you doing during the acute MI? Cheetah. What are you doing the acute stroke? Cheetah. Got it? Then the regular people. Remember the Chad score. What was it, the thing that really tipped the scale? It was age, guys. Once they started at 65, they got a Chad score. Once they got to 75, they're high risk. Previous stroke, high risk. He's getting it. Makes sense? So that's the test question about the 67-year-old gentleman who comes in with AFib, currently asymptomatic, rate controlled, blah, blah, blah. What do you want to do? He's greater than 65. He's got to get it. Does everybody see this? Okay. And then we talked about a flutter. In a flutter, what was it? The R wave pattern could be regular or irregular. But on the bottom, when I looked at the trash, it was morphologically the same. It was sawtooth. It was the same. How did I treat a flutter? Same way I treat AFib. I can give them calcium channel blockers. I can give them beta blockers. But the beauty of a flutter is that, do I have to anticoagulate, or can I go just straight to cardiovertin? You're like, oh, I can go straight to cardiovertin. Yeah, that makes sense. That makes sense. So I hope this makes more sense to you guys about AFib, because I know this is like one of those high value subjects and stuff like that. But start viewing AFib from the perspective of like, God, if I'm just lacking oxygen or vasoconstricting, then yep, I'm gonna get the AFib. Just to give you guys a little teaser, watch this. Guys, do you know what you're gonna, if you like, do you ever hang out with the big time mountain climbers, the big ones, right? The big ones that go up there like above, 20,000 feet. What's one of the things you'll see? And when you get through these high altitude sickness people, when they're up here in the high altitude and they didn't get enough oxygen. Yeah, guys, guess what those people ran into? That's right, AFib. Everybody see this? Okay, does that make sense to you? Because they have less oxygen and then they're climbing when there's no oxygen. You're like, your heart's going like, what the do you want me to do up here? You get it? Does that make sense? Now, does everybody see this? Everybody see this from a concept point of view? Because I know in school, you guys sit around and memorize the stuff, and then you're reading PANCE Pearl tips, you're memorizing a PowerPoint, you're regurgitating for a test, and then 5 hours later, someone mentions AFib, and you're like, who's AFib? Is that a sushi dish? Can I order that with a sake bomb? So, got it, guys? All right, guys, it was nice meeting everybody again. Hey, have a happy Sunday, guys. Bye, guys. Bye, everybody.